Today, I want to talk about some preventive tests that will help our heart health. And this is a topic that's of great interest to me because as a cardiologist, I see heart disease every day. I see its varied manifestations. In some people, a heart attack can just mean a day of hospital stay and then they're discharged the next day. For other people, it can mean a lifetime of disability, and in some people, even death. So, I would love to talk to you today about tests that we can do to get to the bottom of heart disease and tests that we can do to prevent heart disease. Just some disclosures, opinions are my own and do not reflect the views of my organization, and all content here is educational in nature. To start with, let's talk about what is atherosclerosis. So, when we talk about the word atherosclerosis, we are talking about the buildup of fats and cholesterol in the walls of your artery. Now, this fatty deposit is called plaque. And if this plaque or plaque continues to grow inside the artery, it can cause a narrowing of the artery. And if this happens slowly over a period of months to years, it can cause symptoms like chest pain when you're exerting yourself, chest pain when you're running, chest pain when you're climbing the stairs. However, if the plaque suddenly ruptures, it can completely shut off the flow to a particular part of the heart, as is demonstrated by this blue circle. And that's what we call a heart attack. When the flow is completely cut off, we call that a heart attack. The big thing to note over here is that the buildup of this fatty deposit, this plaque, it's a silent process. So it can develop even if you have no symptoms at all. You're an active person, you're able to do everything you want to do on a daily basis, you're able to exercise. You can still have plaque that's just silently building up. And the first presentation of heart disease in many people actually is when they have, for example, a heart attack. So we have seen in the news of multiple prominent young people who have suddenly died of heart disease. So what exactly is happening to young hearts? And there's lots of theories about this, right? There's some people that will say it's genetic, some people say it's your lifestyle, it's the stress. And there's a big misconception that whatever is happening is beyond our control and there's nothing we can do about it. So I'm here to tell you today that that is actually not true. Heart disease is one of those things that if we catch early, we can actually make a significant difference to your risk of a heart attack or stroke. Now, when we talk about cardiovascular risk or heart disease risk, what exactly do we mean? So, what we're trying to do is take a group of people who all may look alike and have similar risk factors or similar history and try to parse out who is going to develop heart disease and get a heart attack and who is not. So, we use large data sets of hundreds of thousands of people to sort of pass this out is which way are you going to go based on what your risk factors are. What are some risk factors? So there's a bunch of risk factors that we can talk about. The ones that are highlighted in dark pink are what we call the non-modifiable risk factors. The ones in light pink are the ones that we have control over. So we'll talk about non-modifiable risk factors like age, sex, South Asian ethnicity, for example, is associated with a higher risk for heart disease compared to Caucasians. Having a family history of heart disease and premature heart disease. So heart disease in the young, below the age of 50s, for example, that does increase your risk for heart disease. And then there is a particular risk marker. It's a blood test that you do. It's called lipoprotein A that we'll talk about, which is also genetically inherited. But if you look on the bottom half of this circle, this is everything that we have control over to reduce our future risk for heart disease. So getting your cholesterol under control, treating hypertension, diabetes, eating a healthy diet, working out more, exercising more, controlling visceral obesity, avoiding tobacco use. These are all things that are within our control to help our risk for future heart disease. And small changes that you can make to each of these categories can eventually make a significant difference to your future heart disease risk. I want to spend some time talking about this. So these are things we call cardiovascular risk enhancers. So they're not classically thought of in when we talk about risk factors, the kind of things that we talked about in the previous slide. But if you are someone that has one of these risk enhancers, that can tell you that you may be at a higher risk for heart disease compared to somebody else who may otherwise look similar to you but doesn't have these risk enhancers. So the first thing is women with pregnancy complications. So preeclampsia, gestational diabetes, for example, can increase your future risk for heart disease. So they can be an early sign that, hey, there's something going on within our vasculature, within our metabolism that might portend an increased future risk. People with chronic kidney disease are at a high risk for heart disease. People with fatty liver, this is a growing epidemic among young Indians. And oftentimes I'll hear people say things like, oh, it's just a little bit of fat. My numbers are just a little bit off. It's not such a big a deal. The thing is, it is kind of a big deal because of what it tells you about your long-term risk. So having fatty liver in your 20s and 30s can portend an increased risk of heart disease in the near to distant future. And that gives us a window to intervene on your lifestyle, on your metabolism. And that just helps not only your fatty liver, but also your heart disease risk. So fatty liver is one of those things to pay attention to. The last thing is inflammatory disorders, people with rheumatoid arthritis, psoriasis, inflammatory bowel disease, they can all be at an increased future risk for heart disease. Before we talk about what tests are recommended for heart disease prevention, let's talk about metabolic syndrome. So, what do we mean when we say metabolic syndrome? That is a constellation of findings that might tell you or give you a clue that something is wrong inside metabolically and needs to be addressed. So, some of these things are things you've already heard of. So, abdominal obesity or having a pot belly, having high triglycerides in your lipid panel or your cholesterol panel, having a high blood pressure, abnormal sugar levels. These are all things that can clue you in that there is something going on with your metabolism. When we consider the tests, the first thing to note is that just because you have no symptoms, you're a young individual, you're able to do everything you want to, you're able to exercise, right? That does not mean that there's no problem. There are many, many factors that are beyond our direct control. You remember the dark pink box in the risk factor table? Um, those are things that are beyond our control. Things like air pollution, where you live, the kind of stress you have in your life, those are all things that affect your heart disease risk, but may not necessarily cause symptoms. So the only way you can find out if there is something abnormal with your risk factors is to check. So the tests we recommend if you're under 30 are a cholesterol check or a lipid panel, a blood pressure check, checking your sugar control or your HbA1c. And in certain people, especially if you have other symptoms of metabolic syndrome, then checking for fatty liver may be considered. And that can be done with like at least a blood test, but sometimes we do an ultrasound of the liver. Now, in people who are greater than 30, all of the above things I just told you about still apply, but in some people, we will actually recommend consideration of screening for heart disease. What does that mean? So there are tests we can do like CT scans that actually screen for heart disease, and we'll talk about that. But it's recommended, globally, it's recommended above the age of 40, 45. However, in Indians, because we tend to develop heart disease earlier, there are guidelines that recommend screening if you have, for example, a family history of premature heart disease in young people. Screening can be considered even in your 30s. Let's talk about the lipid panel or the cholesterol check. So we're going to spend a little bit of time on this because this matters, and this is one of those things that is very important for your cardiovascular risk. So people with metabolic syndrome tend to have a very specific pattern in their lipid panel. So they tend to have high LDL levels, high triglycerides, low HDL levels, and the HDL that actually exists also doesn't work very well And that's what we call dysfunctional HDL. So if you see a constellation of these findings, that can be a clue that you have metabolic syndrome going on. Now, when you get a lipid panel done and you get your cholesterol checked, the first number at the top of the lipid panel is the total cholesterol level. Now, you'll notice I actually haven't written total cholesterol anywhere on this slide, and that's intentional. That's because I want you to pay attention to the LDL level. Now, your LDL level, irrespective of your total level, independent of the LDL to HDL ratio, the LDL level alone is an important marker of your heart disease risk. The second test that I think is useful mentioning for those of you that want to take the next step is an apolipoprotein B or an ApoB level. Now, this is not on your routine lipid panel, so you have to order it separately and you have to ask for it, but it can give you a lot of extra information about your risk. Now, if you'll bear with me for a second, we are going to do a little bit of a deep dive. This was requested by multiple people, so we are going to do a little bit of deep dive into what is LDL, what is ApoB, and at the end of it, if all of this becomes too much, I'll give you the highlight. So a lipoprotein is this particle. So it's the particle that contains the protein. It has cholesterol, it has fats from your diet and fats from the liver. It's what transports cholesterol in the blood. When we use the word LDL, we're referring to a specific kind of lipoprotein called a low-density lipoprotein. And in the picture here, both of these particles are LDL particles that I'm showing you. Now, what is LDL-C? LDL-C refers to the mass of cholesterol within these particles. So whether it's this or this, the blue, if you sum all the blues up here and here, that's going to give you the LDL-C level. Now, that is the number that you're seeing in your routine lipid panel, where you see the total cholesterol, HDL, LDL cholesterol, you see triglycerides. That it refers to the mass of cholesterol, all the blue within these cholesterol particles. Now, ApoB is a slightly different metric than your LDL-C. What the ApoB tells you, it's the number of the LDL particles that you have. So it's a measure of that number. So for example, on the left here, I have 8 particles. On the right here, I have 12 particles. So the ApoB is going to be higher on the right compared to the left. However, you can imagine, because I have larger particles here and smaller particles here, the LDL-C, the total amount of blue within these two tables are going to be kind of equal. So on the left and the right, the amount of blue may be equal, but the ApoB will be higher on the right. And it turns out that as your ApoB goes up, your cardiovascular risk actually goes up. So even if you have a quote unquote normal HDL level, I'm sorry, a normal LDL level, you can still have a higher ApoB, and that's a hidden risk factor for you. So if you don't check it, you're not going to know that you have a higher ApoB just by looking at your regular lipid panel. And it turns out that people with metabolic syndrome tend to have this discordance where your LDL may look good, but your ApoB is high, and you have that hidden risk that you're not catching unless you go take a look. So if that was all too much, the highlight version of it is check your lipid panel. If you have metabolic syndrome, check that ApoB number. It's a blood test. You don't care about the ApoB to A1 ratio per se as much. You just want that ApoB number. And I'll give you targets and everything in the future slide. So we talked about lipoprotein A a little bit when we talked about non-modifiable risk factors. So lipoprotein A is a lipoprotein. So it again carries the cholesterol. It has got protein, carries the cholesterol, but it's a little bit different compared to the LDL particle. This is genetically mediated. So you either have an elevated lipoprotein A or you don't. So we only recommend testing it one time. The reason it matters is because it is associated with premature heart disease. So when you have a clustering of premature heart disease in the family, multiple members have had heart disease in their 40s and 50s, we test for lipoprotein A. It's a blood test that you do. You only do it once. And then there are different cutoffs depending on Western organizations tell you like greater than 50 milligram per deciliter. is elevated, but there's some data in Indians, even as like low as 20, may be elevated and may be associated with an increased risk. Um, as of today, there are no treatments per se to significantly lower lipoprotein A and lipoprotein A mediated risk. However, it can be one of those risk enhancers that we talked about, where if we're on the fence whether or not you need treatment and whether or not you need your other risk factors aggressively controlled, an elevated lipoprotein A can kind of give us that push that tells us, yes, we do want to be a little bit more aggressive with your other risk factors. So that was about lipids. I want to spend a second talking about blood pressure next because blood pressure matters. High blood pressure is a global risk factor everywhere for increased heart disease. And we in general do a really poor job of keeping blood pressure under control. Um, Oftentimes I will hear people say, oh, my blood pressure is only in that yellow range. It's only in the stage 1 range. Stage 1 is about 130 systolic, right? I'm not going to do anything about it. It's not a big deal. If you can look at this graph here on the right, they have looked at the risk of heart attack. So how many people with normal blood pressure versus stage 1 hypertension, which is the 130 systolic cutoff, have a heart attack. And it turns out, even at 130, your risk for heart attack is higher compared to maintaining a normal blood pressure through your lifespan. So, really, we want to be trying to maintain a normal blood pressure through our lifespan. The similar data exists with stroke as well. So, it's not just heart attacks. These are the latest hypertension guidelines that came out this year, and they recognize this risk. So, what they say is if your blood pressure is over 130, over 80, but you're in low risk, you don't have other risk factors for heart disease, and there are calculators we can use, um, then you have time to try a lifestyle. So, that can be, following a DASH diet, watching your sodium intake, eating more fruits and vegetables, less processed food, more whole foods. And you can try all of that, increase your exercise, minimize your sedentary time. And you can try all of those things. And if it works, that's great. If it doesn't work, your blood pressure is still elevated after, say, 3 to 6 months of a lifestyle trial, then you need medications. Similarly, if you are at a high risk, you already have risk factors, you have diabetes, kidney disease, you already have heart disease, then you don't want to leave your blood pressure at over 130 over 80 because you are putting a stress on your vessels that supply the heart, the kidney, the brain, the eyes, right? And high blood pressure tends to damage all of these organs. So then we recommend upfront lifestyle and medication. Similarly, if your blood pressure is over 140/90, again, upfront lifestyle medication is recommended. And that doesn't mean that lifestyle doesn't matter. It still does. In fact, I have patients in my clinic who I have taken off medications because they really turned their lifestyle around. They lost a bunch of weight, they changed how they're eating, and now their blood pressure is normal. Great, then we can peel back the medication. What we don't want to do is leave you at 140/90 for years and years and years, because that's how you will damage a lot of the organs. So that increases your risk for heart attacks, for strokes, kidney disease, that kind of thing. Okay, talking about visceral adiposity and diabetes. Visceral adiposity is the bad kind of adiposity. So it's the fat that's in your belly, the fat that surrounds your liver, fat that surrounds the heart. That's the kind of fat that causes damage to different organs. And in South Asians, unfortunately, we tend to have predominantly a visceral adiposity pattern where even at a lower BMI, we tend to have more adiposity, more fat percent compared to, say, Caucasians. So global guidelines recognize that in South Asians, your cutoff for a healthy BMI is under 23. And for if you're really interested to get at your visceral adiposity, even if you have a normal BMI, you can check a waist circumference, and having a high waist circumference is a better surrogate of having visceral adiposity compared to a BMI. And all guidelines recommend if you have a BMI greater than 23, they recommend screening for diabetes. So really, it's not a very high BMI that it puts us at an increased risk for adiposity and obesity related complications. So how do we screen for diabetes? There are two tests that are recommended. The hemoglobin A1C, it's a simple blood test. It tells you a 3-month average of your sugar control. You can also, in some people, we do a fasting glucose, and then after 2 hours after a meal, sometimes 2 hours after standard meal, we'll check a postprandial glucose, and that'll tell us if how your fasting is, how your response to food is, and that can give us a little bit extra information about how your sugar control is. So we talked about this a little bit. So we talked about how do you screen for heart disease? And why is this important? This is important because no matter how healthy you think you are, your risk factors may be under control. There are still risk factors we A, cannot control for, like our genetics and a family history, but B, there are things exogenous to us, like the pollution we live in, right? And there are things we don't even understand that might raise our risk for heart disease. So in people with a lot of risk factors, or in people who want to be proactive and want to get checked, this is a good test. It's called a calcium score or a coronary artery calcium score. This is a low radiation CT scan that you get. You can get it in like 10 to 15 minutes, and that tells you if you have calcified plaque in the arteries of your heart. So this is what a CT scan looks like. This is a picture of the heart right here. And this is one of the arteries that supplies the front of the heart, called the left anterior descending artery, also known as the widowmaker artery in common parlance. What this is showing you is you have a fair amount of white stuff. That's the calcium that's deposited in the arteries of the heart. And that tells us that you have plaque deposit in the arteries of the heart, and atherosclerosis has started in your body. Even if you have no symptoms, this can still give you a little bit of information about what is going on inside. So, who should get a coronary artery calcium score? The first thing is it's only recommended for people who are asymptomatic. So if you have symptoms such as chest pain, or you're getting short of breath when you're exerting yourself, you need different tests. This is not for you. It's recommended in people who have borderline risk. So when we look at your many risk factors, we're not really clear if you need a medication or not. And sometimes you're sort of in the borderline range. If we get this calcium score, that can tell us that yes, you have a high calcium score, you are at an increased risk, or no, your calcium score is 0, you're not as much as a high risk. So that allows us to tailor medications in a way that's personalized to you. It's not recommended if you have a known history of heart disease. So you had a stent, a heart attack, a bypass. We know you have heart disease. You don't need a calcium score. You don't need a screening test. Again, people with risk enhancers, like we talked about, like preeclampsia or family history, you don't have traditional risk factors, but you have some of these in your family history, this can be a useful test. We don't recommend it if the test does not change management. If you're already being treated aggressively for your risk factors, then a calcium score is not recommended. So this is a busy slide, but I thought this was interesting to share. We now have South Asian specific data for your risk for coronary artery calcification. And we didn't really used to have this up until like last year. We basically extrapolated a lot of the data from Caucasians to South Asians. Now we actually have data that is South Asian specific. So these graphs now tell us where your calcium score should fall compared to peers of your age, your sex, and South Asian ethnicity. So the calcium score can range from like 0, meaning no calcification, and it can go, as high as like 2,000, 3,000, 4,000 or higher. And lower is better, 0 is the best. And as you go higher, that's a higher calcification burden. And we now have graphs that tell you, depending on where your calcification burden is, what is your risk for, no, actually, where do you fall in relation to your peers, people of your own age. So, taking a 39-year-old man as an example, so that brings us to this graph here on the right. So, age is at the bottom and the score is at the top. And this is cropped out at 140, but really it can be even higher. If you are a 39-year-old man and you have a calcium score of 20, that puts you at this green graph, and green graph is at the 95th centile. So you are at the 95th percentile for age and sex. So compared to all 39-year-old men of South Asian ethnicity, if you have a calcium score of 20, you are higher than 95% of people your own age, sex, and ethnicity. So that is actually a big deal. If the number 20 doesn't look super bad, it's actually in the mild range, but because you're having this number at the age 39, that tells us that your future risk for heart disease over the next 10, 20, 30, 40 years is actually quite high. So that can be kind of an early sign that there's a problem. Most 39-year-olds have a much lower calcium score than even a 20. So the calcification increases as you age. Now, the Lipid Association of India does have treatment guidelines based on your calcium score. So notice that they start at age 30 because, like I said, South Asians tend to have a premature, younger age of onset of heart disease. So if your calcium score is 0, that's great. You don't have calcified plaque. Especially if you're younger, that's the norm, that's expected. That doesn't mean you can, forget about lifestyle. The metabolic syndrome still matters, that the other risk factors, the cholesterol, the blood pressure, all of those still matter, but it's a good sign. You haven't started putting on calcified plaque yet. Now, if your calcium score is in that mild range that I talked about, like 1 to 99, um, that doesn't mean you're off the hook, but if you are at the greater than 75th percentile, so like in the example I showed you where the person was in the 95th centile, that actually is a high risk phenotype. That means we have to be aggressive about lowering that risk so we can change your trajectory. If you were on the trajectory to develop heart disease and develop things like heart attacks, we can move that curve down and treat you to reduce your risk. Similarly, if your calcium score is over 100 or over 300, that does put you at a pretty high risk. And we want to be aggressive about lowering your cholesterol and your other risk factors to minimize that risk and change that trajectory, just like we talked about. So this again is from the Lipid Association of India guidelines of 2023. So they recommend if you're at a lower moderate risk based on your calcium score, your LDL should be less than 100 and your ApoB should be less than 90. Remember, we talked about ApoB being that additional test that you can get. And again, notice that even if you're at a lower risk, nobody is recommending that your cholesterol be in the 140s. I often see people say, hey, my LDL is 140, but I'm healthy. I've got nothing else going on. It'll be okay. I'm just going to leave this as is. Not true, because a high LDL over your lifespan can lead to future heart disease. So you want to keep your LDL less than 100. That does not necessarily mean that you need medications, depending on how much lifestyle changes you can make, like weight loss can help, cutting out the saturated fat, the processed foods, the sweets, that kind of thing. They can all help with lowering your LDL level. But if you're at high risk, like in that second table that I showed you right here, if you're at high risk, your LDL goal is less than 70, your ApoB goal is also like 70 to 80. Whereas if you're at extreme risk, like right here, your calcium score is greater than 300, or you're someone who's already had heart disease, then your LDL goal is pretty low. We want your LDL like even less than 30 if we can get it. There's a ton of literature showing the lower the LDL in these extreme risk people, the better it is for you. And it's safe to go like as low as even 30. So I want to address some common things that people ask me in my clinical practice. People think that, hey, if I have a positive calcium score, that means I have blockages, right? That means I need a stent. No, not necessarily. In most people who are asymptomatic, even if you have these blockages, you don't necessarily need a stent. Medical therapy is very effective. Outside of certain scenarios, most people don't actually need a stent. The second thing I get often, especially from my Indian patients, is, hey, if I have a positive calcium score, this has already happened. I've already have blockages and I'm doomed. There's nothing I can do about it. Again, not true. The whole reason we're doing this test is because remember, we can change that trajectory and take you from the higher risk to a lower risk with preventive therapies. So the reason we're doing this test is because we have that window where it's not causing you any problems right now, and we can meaningfully modify that risk. Third thing is if you have a calcium score of 0, especially if you're young, that does not mean you are immune to heart disease. It doesn't mean you'll never develop it. You still have to watch your lifestyle. And sometimes we'll, depending on your risk factors, we'll even repeat it in a few years to see if that's changed, and kind of do serial calcium scores to see if your risk has changed. For those of you that have watched the Brown Hog documentary, this is going to be familiar. This is the sort of an overview of all your parameters, like where do you want your blood pressure, where do you want your body mass index. These are the cutoffs for waist circumference. Remember, I told you take a tape and put it around your waist and look at your waist circumference. So less than 90 for men, 80 for women. We want your LDL as low as possible. We want your triglycerides less than 150. This is a very diet fixable metabolic syndrome risk factor. And then ideally, you want to have a calcium score of 0, meaning you have no plaque. Now, if you have a calcium score that's not 0, we can still make a difference to your risk for heart attacks, risk for strokes, by addressing all of these other risk factors that are very much within our control. So for those of you that are living in the US, there are South Asian specific heart centers that have people that are interested in this space, that are aware of the increased risk of heart disease and premature heart disease in South Asians. This slide I borrowed from the South Asian Heart Center in California, where you can get a comprehensive risk assessment of the drivers of atherosclerosis, drivers of inflammation, metabolic syndrome, and you can get coached to improve a lot of these lifestyle factors. Similarly, multiple hospital systems, like I'm in Austin, there are others in Bale Scott and White in Dallas, Leahy in Boston, UT Southwestern. And then we have a huge need for research in the South Asian population. A lot of our guidelines are extrapolated from Caucasians, from Western data. We don't have a lot of data in South Asians, but there's a huge group of researchers that are trying to fix that. So I would encourage you, if you can, to participate in one of these studies. So the Masala study, um, Our Health is a genetic drivers of cardiovascular disease study in South Asians based out of Boston, and they have a kit that they can send to you that will then looks at genetic markers that might portend an increased risk in South Asians. This here on the top is a document that was published by the American College of Cardiology that has a list of multiple different South Asian specific centers. It's a little old, so it's from 2021, so a lot of new centers have come up that I've tried to highlight here, but this has a comprehensive list. If you're living in the US and you're interested in seeing a specialist with awareness of this, this is a good document. And then the Brown Heart documentary itself that I want to plug has a lot of interesting and useful information on how do you address your risk, how do you screen for it, what do you do if you have an increased risk. So these are all things that will hopefully be helpful. Okay, with that, I want to end for today and thank you for your time.